So we're talking about stand monitoring. Yes, some of us have been using it for a while. Some of us have used it somewhere else. And we all know that the guideline is changing. So it's important to actually talk about the stand guideline and how this is going to affect us and affect our lives and affect our patients. Okay. So stand monitoring is actually, so it's a combined fetal monitoring and stand analysis. And the emphasis is in combined fetal monitoring. It always starts with fetal monitoring. Okay. And then comes the ST analysis. It is an adjunctive technique. It is a way of trying to figure out things when things are confused. If we are not confused, we should not try and muddle ourselves up. Is that clear? And that statement is very, very important, because if we are not muddled up, if we think that this baby is not hypoxic, we should not get alarmed or confused by stand messages. Okay. What we're gonna try and do and cover is what's the theory behind stand, what's the whole idea behind stand, and what's the basic principles. Okay. Then how do we apply this into practice? How do we interpret them? And the pitfalls that we can fall into. The pitfalls part is going to be more of a discussion than any screen or slides. Okay. Let's start off with the basic bit of theory behind. I have, oh, no, sorry. Guys, can you see my new screen now?
Yeah,
Yes.
I thought it was a map for like a wedding party or something where you're going to seat everyone.
Yes. So unlike the seating area or plan, you can see two areas, so cardiac muscle cells and the extracellular space. Okay. This is basically a muscle from within the heart. And like all muscles, or like all cells, sorry, our cell membrane has sodium-potassium pumps. So this is the pump that is supposed to be keeping the concentration of potassium higher on the inside and sodium higher on the outside. The cardiac muscle, similar to many muscles, has also something called an ion gate. An ion gate is a gate that opens up, allowing ions to cross over. It's a fast acting. So if it does happen, the outflow of or inflow of minerals across is usually faster than whatever the pump can actually do. You end up with almost an equilibrium state when it opens. Okay. Normally, any muscle or nerve, or similarly the cardiac muscle cells, are polarized, meaning that there is more potassium on the inside, there is more sodium on the outside. Because of the difference in concentration of potassium and sodium and the difference in ions, there is a charge on the cell membrane of the cell. Okay. Now, if this is to depolarize and the ion gates open, the minerals will cross and will reach an equilibrium. So they're basically similar number of potassium inside and outside, sodium similar number on the inside and outside. Okay. As the gates close, and then as the heart repolarizes again, the sodium is pushed out, the potassium is pushed in, and we reach a state. Now, if anybody can remembers the any laws of physics or electricity within physics, charge or electricity flows when ions are moving. When ions are sitting in a steady state, there is no move of electricity. So if we look at an ECG signal, so if let's share this again. If I look at an ECG signal, there's a P, QRS, and a T wave. Okay. The P is the sum of the depolarization of the atria. And the QRS is the sum of the depolarization of the ventricles. What does sum mean? Okay, it's not just each individual cell. So not every cell will create a P wave. It's all the cells of the atria together that creates the P wave. And all the cells of the ventricles together creates the QRS. Does that make sense? Okay, if it's making sense, why does the P wave look the way it looks like and the QRS look like this? I thought it should be the same. So the ventricle is slightly more in volume. It should just be a bigger wave rather than this weird shape. Yeah. Hello.
It's a very good question, Ahmed.
Thank you. I tend to throw good questions along the way.
That means I don't know the answer.
Okay. So the electrical impulse spreads within the atria as a whole, as everything. It just spreads everywhere. It starts from the SA node and spreads everywhere within the atrium. Yes? So most of the atrium is depolarizing at the same time. So the ions are just flowing within this mass pretty much at the same time. So that's why the smoother curve. But the ventricle, it doesn't work that way, does it? The ventricle works with the Purkinje fibers. So the depolarization actually follows a path. It's that path that creates that weird shape. I'm not trying to do this to sound smart. The reason I'm saying this for a very good reason, for a question that is about to follow. Okay. Now, the T wave is the repolarization of the ventricles. The repolarization of the atria is missed, so it's covered up or masked by the QRS complex because it's too big. So we're not going to worry about that. But the T wave is when the ventricle tries to repolarize again, pushes the potassium back in and sodium back out. Okay? Does that make sense? So basically now I have this pump that is working all the time, making sure that I have this gradient, keeps the potassium inside and the sodium outside. And this pump is very important to the function of the heart. Okay, now this pump, let's assume that I need a single glucose molecule to power up this sodium potassium pump. Okay, now if oxygen is not there anymore, if oxygen stops and disappears, this metabolization of glucose is not going to produce the same amount of energy that it used to produce. So when oxygen is present, glucose produces 38 ATPs of energy. Yes? If oxygen is not present, it only produces 2 molecules. Which means that this single poor glucose thing is now only providing 1/17 of the power required to power up those pumps. So the only way to do that, to power up, is basically to just get some more glucose, no? Where do I get glucose from?
Glycogenolysis.
Glycogenolysis. So basically I need to go back to the glycogen stores and get some more glucose, okay? Which can happen naturally. It's not an abnormal process. It's not an unnatural process. The problem is that in the process of giving us glucose, it actually produces more potassium. So essentially what it does, it's actually going to increase the workload of the pump. So now that when you have to repolarize or when you're depolarizing, there's a lot more movement along the way. Does that make sense? So So if this was supposed to be my repolarization process, if I'm now moving more ions across, what do you think is going to happen to the T wave?
Going to increase?
So it will get bigger, yeah? Sorry. It will basically get taller. That's the first effect of the, sorry, you guys are in the way of my presentation. I need to move you out of the way, sorry. So basically, as I said, the T wave is going to increase in size because there's more potassium to cross, hence it's going to become taller. What happens if I increase the potassium even further? What's the next sign of hyperkalemia? Hello? You guys have obviously been doing Obzangani for too long. You need to read something else apart from Obzangani.
Hold on, I'm Googling it.
Yes.
You're
Something
Googling
with
it.
the QRS complex.
Yes. So it becomes wider
Next
because it's
section
going to
is
take,
parallel.
it's going to take longer for the potassium to depolarize. And as it gets worse, the QRS complex is actually going to become, so especially the R wave is going to become quite taller because there's more ions to cross. Okay. But we're not trying to reach when we are in severe hyperkalemia. We're not trying to diagnose hyperkalemia. What we're trying to diagnose is the first signs of hypoxia. We're trying to diagnose when the first glycogen is being broken down to give glucose. Hence, the slight increase in potassium that happens with that. So what we're looking at is trying to assess how tall the QRS, the T wave is compared to the QRS. Because the QRS is pretty much stable for most of the ECG, unless there's severe changes happening. The height of the QRS is pretty stable. So I'm gonna use this as my baseline point or my benchmark to try and compare this T wave to the QRS. The idea is I'm trying to create a value or a ratio that is very specific to each baby independently, not compared to a population, but compared to a single baby to itself. Does that make any sense?
Yes.
Okay. Now, if the hypoxia is happening all of a sudden, and there's suddenly not enough oxygen, hence not enough glucose to power up the pump, what do you think is going to happen? So suddenly, the pump is, let me go back there. Suddenly, this pump has no oxygen whatsoever to keep it working. What's going to happen to the T wave? Will the pump be able to repolarize the membrane?
No.
No. Or, more commonly, I mean, if it's absolute, there is no glucose whatsoever, full stop, none, zero, it will be completely flat. There will be no T wave. Okay. However, what normally happens is that as it's working, it falters. It tries to push a bit in, and then it stops, or some leaks out, and then it pushes the bit up again, and then it stops. Yeah? So the T wave changes shape. If it's faltering, if it can't push the potassium and so can't push the potassium in and the sodium out, and it doesn't have enough energy to do that, it starts wiggling the wave. Rather than having a smooth, nice wave, it's a odd-shaped wave.
But we ignored the biphasics.
No, we didn't.
Oh no.
We didn't ignore the biphasics. We ignored the episodics, not the biphasics. Yeah. So basically, what we're trying to do is we are trying to get an assessment of the CTG to try and figure out whether baby is well or not. Physiologically, we're trying to figure out whether baby is well or not. And if baby is well, that's fine. We don't need anything else. If baby is not well, or we're not sure, then we need to look deeper to see whether the baby's heart is undergoing extra needs or extra problems as it's beating. Does that make sense?
Yes.
Absolute silence again.
Yes.
Okay. So how do we apply STAN? We know that STAN, we need to work through an FSC, yes? So a scalp electrode that attaches to baby, that is supposedly picking up baby's heartbeat signal. Can I rely on that to figure out what the baby's ECG looks like?
No.
Why not?
Feels like it won't be 100% accurate. So you have, that's why it's an adjunct, right?
Okay. Is the FSC enough for me to just figure out the baby's ECG to start with?
Yes.
You need
So if
You
you're doing
need
an ECG,
pad
I need the skin pad, the skin tag, yes.
cancel out
So
mum's ECG.
to cancel out mom's ECG. So if you're doing an ECG, you always ask a lady to touch nothing, okay? And not move as much as she can. You're trying to cancel out any dampening effect from whatever she's touching. And you're trying to cancel out any electrical impulses coming from the muscles. This baby is sitting inside an entire big woman who's actually 10 times his size, producing almost 10 times the amount of electrical signal from her heart and from her muscles than this baby. So what you're trying to do is use this, the skin tag is trying to earth out the signal coming from mom. That's why if this is not on properly, A, you're not gonna be getting a good signal from, so a good ECG signal. B, you're gonna be getting a lot of interference. Okay. The other thing is anything else that is producing an electrical impulse can interfere with your FSE signal. So if you put a mobile phone next to the machine, you can interfere with the ECG signal. If you put a TENS machine on mom's back, you can interfere with mom's signal. If this is actually touching the maternal cervix or vagina, it may interfere with the signal, which is why the babies that have a very low head, we go in and try and put an FSC and yet there's no impulse. Those that are just at 1 centimeter cervix and you're trying to put it in and then the FSC cable is actually pulled in and it's literally just squashed between the cervix and the head, you frequently get very little signal. Does that make sense?
Yes.
Okay. So we said that we want to start this, so we want to compare this baby to itself. We want to use each baby as a separate entity and not refer to curves or population curves. So what we need to do is once we put this clip on, the machine starts picking up an ECG signal and it keeps record of every single beat for the first 4 minutes. Once it's got the 4 minutes of trace, what it does is it compares, it puts them all together and comes out with an average wave. That's the standard wave for this baby. This is now what I'm going to be comparing to for the rest of labor. This is my benchmark that I'm always comparing to. And as we said, this baby is within mom. So there is a possibility that we can be picking up mom's ECG. The theoretical assumption is that because the P wave is so small in most ECGs, if you're picking up a P wave, you are usually correctly picking up baby's ECG. If you can't see a P wave, then most likely you are picking up mom's ECG. So if you see, you have to be able to look at this and see, okay, well, there is a P wave, there's a QRS complex, and then there's a T wave there. So that means, okay, I am picking up baby. Does that make sense? Guys, are you still there?
Yep.
Okay.
Makes sense. Yeah.
But this is not absolute, okay? And that's very, very important. We've seen cases when babies have shown, so we've seen this wave and this turned out to be mum. And Rosie can tell you about the case that actually happened at St. George's with that, okay? So yes, it's an indicator, but it's not an absolute fact. Now, what the machine is looking for is comparing all the time, comparing how tall the QRS complex to the T wave to look at the ratio. And it's observing it every 30 beats, it picks up, it compares an ECG signal to the previous one. The next 30 beats, and it compares it again. It's also looking for that faltering of the T wave. And that's when it alarms. So it's either going to tell you I have a problem with my ratio or I have a problem with the shape. The shape is called biphasics. The ratio is, sorry, it's telling me I have an unstable connection. Can you guys hear me still?
Yeah, you cut out, but you're back.
So as I said, it's comparing two things. One is the ratio, so the QRS-T ratio, and the shape. QRS-T ratio is telling you whether hypoxia is gradually happening, whether there's more glycogen being broken down. The biphasic is telling you whether there's suddenly an acute episode when the pump has suddenly stopped working or is faltering, which is why this is showing. Okay. Now, how do we interpret this? This is what the changes look like. This is what the machine is looking for. How are we actually interpreting this? Okay. How do we apply this into real practice? Are we okay so far? Are we still following?
Yeah.
Cool. So a bit of prerequisites before we are ever starting. And I'm sure we've all seen this now. Gabby has shown this on all the teaching sessions. Let's go through this bit by bit. Let's see who can we use it for first. Okay, remember, this is taking a baby for itself, it's comparing it to itself. It takes some time to establish a baseline, and it now needs to monitor the baby. So prerequisites before we're starting, okay, this technology has not been tested earlier than 36 weeks. Hence, we can't apply this to anyone who's less than 36 weeks, okay? Theoretically, what do you think can be different to a smaller baby than a term baby? What would be different?
With the fetal ECG?
Yes. Why am I not using it on a 34-weeker? What's the problem?
Do they use their energy stores differently and so would end up with a different ECG?
So potentially. So they may be less efficient with dealing with their glycogen stores, okay? Do they have the same amount of glycogen stores?
No.
Okay. Do you think they have the same? Sorry?
Less?
So they may have less because they're preterm. They haven't built up the stores because they were not getting ready for delivery yet.
Yeah.
Do we know what we monitor? So what do midwives monitor the preterm baby for? What does their monitoring for preterm baby comprise of?
Temperature control.
That's one. Okay. Blood sugars? Do they monitor their blood sugars and make sure that they're eating and that their BNs are not dropping too far?
Yeah.
Yeah, because they do not have the same homeostasis for glucose as a term baby. It's not just about glycogen stores, it's also about glycogenolysis not being as mature. Okay. In addition to that, we have no idea what the baby's ECG looks like at 34 weeks, because theoretically, if the baby is immature and the baby's functions are immature, can the membranes also be a bit more leaky? And then the sodium potassium balance may not necessarily be the same. And then the pump is trying to push things while it's leaking from the other side. Yes? Does that make sense?
Yeah.
Okay. So that's why we don't use it less than 36 weeks. A, we have not tested it, and B, there may be a different mechanism or a not fully mature mechanism for glycogenolysis and energy provision. The membranes obviously have to be ruptured, otherwise you can't apply an FSC. Yes. Patient has to be in first stage of labor or passive second stage. Why? What difference does it make? It's the same baby. What difference does it make? Who cares about which stage of labor?
It's about establishing the baseline, isn't it? And so the baby's under stress in the active second stage.
Yes. So it's the knowledge that we are taking the baby as its benchmark for itself. So when you're trying to establish a benchmark or a baseline, you need to make sure that this baby is in a stable state. Not
Next
in a
station
state.
is London Marylebone.
Oh, somebody's on the tram. So we need to establish that this baby is in a steady state. If the baby's state is changing, we can't really get a baseline for this baby that is reliable. So that's why we don't use it unless she is in first stage. We need to make sure that the baby is stable at that point, or in passive second stage. So even if she's fully dilated, that's fine as long as the baby is, again, at a stable state. Okay. One of the other contraindications is precipitate labor. Things are progressing super fast. So I've started this, she's 2 centimeters, she's now 6, she's now fully in, she's pushing all within the hour. Can I miss something within this progress? That's why I'm saying this baby has to be at a stable and steady state. Basically, you need to make sure that this baby has a stable baseline, maintaining variability, so it's not hypoxic in itself before you're starting. And it is stable, because even if the baby is very active, just it being very active, we also break down glycogen when we're active, yes? Because we need glucose to power up these movements. So you have to get it at a time when baby is more or less quiescent, not actively doing something. Obviously, if there's a contraindication to a fetal scalp electrode, so we can't put a scalp electrode on baby, then we can't utilize STAN analysis. And if she's not happy with it, we wouldn't just push and go ahead with it regardless. Does that make sense?
Yes.
Once you've established your CTG, before anything at all, you need to figure out whether you can actually use STAN. So one, can I use STAN? Am I okay with all of this? Yeah, so number one, am I okay with all of this? Number two, what is my CTG doing like? So is my CTG showing chronic hypoxia? In which situation I can't use STAN? Do we know why?
You're asking why we can't put Stan on a chronic hypoxia?
Yes.
Because that baby needs to be delivered.
And they've already used up their glycogen stores, maybe.
Yes. They've already used up their glycogen stores. So yes, obviously, Natasha, this baby needs to be delivered. But if I'm in the process of delivering her, I can't use Stan to monitor because this baby has already used up its resources. It can't start using it more, or it can't give me more. Even if it can, or it has a tiny bit more of reserve, it might not be high enough to reach the threshold for Stan to start alarming. Does that make sense?
Yeah.
Yeah.
Remember, you have to start when the baby is at a steady, well state. You're comparing the baby to itself. It's not like when I'm going in with an MI, okay, and I'm doing an ECG, and you're comparing my ECG to what normally an ECG looks like. In which case, yes, you can put on me for the first time when I'm already having a heart attack, and you can diagnose a heart attack. The machine is trying to compare the baby's ECG to itself. It's not comparing it to a population of babies, which is why if you put it on a chronic hypoxia, the machine is now assuming that this chronic hypoxia state is the norm. And this baby has to be much more unwell before it starts alarming. So what happens if you put it on in a chronic hypo? You walk onto a shift, somebody has already started Stan, you go back to the trace, and you can see that it was started on a chronic hypoxia baby. And now you can see that Stan is alarming. What does that mean?
The baby's dead.
Hopefully not, it still has a heartbeat, but it is a lot significantly worse. So you have to take it even more seriously. You have to act even faster. Does that make sense?
Yeah.
Okay. What about chorioamnitis? So if we diagnose a baby with suspected chorioamnitis, can we use Stan to monitor this baby?
No.
Why not?
Because you're not going to get a Stan event because it's a different kind of pathway.
It's a different mechanism.
Cause, yeah,
Yes.
That's our mechanism.
Yes. So Stan is looking for hypoxia. Your baby here is being damaged by infection. They're very different. Stan is not picking up infection. Can chorioamnitis show in any way on Stan?
Is that when you get the biphasics or something?
You can also start getting biphasics. The reason being is that the cell membrane is more leaky once again. So even though the pump is working fine, the cell membrane is just allowing the molecules to come through the actual cell membranes. Remember, sodium and potassium are generally quite small, so they can pass through the cell membrane had it not been for the pump. If the pump stops, the potassium will leak out and the sodium will leak back in. So if the membranes are too leaky, it may be too leaky for the power of the pump. And you end up with sodium being pushed out and then it leaks back in, and potassium being pushed in and then it leaks back out. You end up with those funny shaped T waves again. But this is not, it's not the same mechanism. This is not because of hypoxia of the pump, it's because of damage of the cell membrane. I'm not saying use the biphasics to diagnose chorioamnitis. I'm saying that that's a common finding with, okay, but you can't use Stan in chorioamnitis, whether it was there at the beginning or as it develops along the way, because it's an entirely different mechanism. Stan is not going to alarm with that. Okay, is that making sense?
I have a question.
Yeah.
If the CTG Stan was applied when she was not chorioamnitis,
Yes.
and then it develops during the stages of labor, and it
Yes.
shows biphasic, can we use biphasic to deliver the baby?
You shouldn't
If
use
it's
Stan to deliver the
subclinical.
baby. If you're seeing subclinical chorioamnitis, as the labor is progressing, you should need to reconsider how far along the labor and potentially deliver her.
Okay.
It's not because of the biphasics, it's because of the chorioamnitis.
No, like
If
it's just subclinical. So to substantiate your diagnosis, can you use biphasic as also pointing towards that?
No, I said STAN is not used to diagnose sepsis. STAN is used to diagnose hypoxia. That's what it's looking for. If you start seeing biphasic because of subclinical chorioamnitis, okay, if you're missing the point, then look at the subclinical chorioamnitis again. But you're not going to use the biphasics to diagnose the subclinical chorioamnitis. You should use your physiology.
Yeah.
Now, remember what I said at the very beginning. This is fetal monitoring supplemented by ST analysis. So if you have a normal trace, or if you have a stable baby with no signs or no suspicion of hypoxia, so whatever bits of stress that it's seeing or having is well compensated and baby is compensating with that, then ignore STAN completely. You do not need to start muddling things up by asking the question that you were not supposed to be doing. Remember, glycogenolysis is a physiological process. It happens when we move. It happens when we're active. It happens when we're awake. The fact that you sometimes have a bit of glycogen being broken down is normal. What we're looking for is glycogen being broken down when there is other signs indicating that there may be hypoxia. Does that make sense?
Yeah.
Okay. So jumping towards the very end, if this baby is suddenly going through an acute episode of hypoxia or an acute event, then we're not going to wait for STAN to save us or tell us that something's wrong. If I can see that this baby is already physiologically going through an episode of prolonged hypoxia or acute hypoxia, then I'm not going to wait for STAN to alarm or not. I really don't care about STAN anymore. We've literally just crossed over from compensation phase to this baby's dying phase. If the baby's dying, it's not going to have enough time or energy to produce glycogen or break it down or even think about any of this. The brain will suddenly go into ischemia and the heart will have to pump as far as it can go and then stop, which is why in acute hypoxia, we're not waiting for STAN to alarm. Or if it's pre-terminal, so this baby's brain was already gone, okay, I can't see any responses or anything that's on there, I will need to act and not wait for STAN once again. In pre-terminal cases, most of the time, STAN, the damage is already, or the changes are beyond the scope of STAN anyway. So out of the entire scope of physiology and CTG, we are left with two situations. We are left with the baby that's going through gradual hypoxia, was stable before, is showing ongoing stress at the moment, and is bordering to beyond between compensation and decompensation. So this is the baby that was showing hypoxic events or hypoxic stresses before, and has now started to decompensate, has started to redistribute, has started to release the catecholamines, starting to use the extra resources, okay? At the beginning of the redistribution phase, when adrenaline is first secreted, the baby is completely fine. The other end of the redistribution or compensation phase is when baby suddenly starts to decompensate. What we're trying to figure out is if the baby, whether the baby is reaching the point of decompensation, because that's when the baby's heart glycogen stores around the heart are being broken down. Does that make sense?
Yeah.
Similarly, in subacute hypoxia, when it's moving fast towards decompensation, basically it's pushing baby from compensation to decompensation before the time it's even getting the chance to secrete adrenaline for redistribution. So you're basically bordering decompensation. That's when STAN is helpful. So when you get, or if you get a STAN event, or before that, we've applied STAN, we've decided who we can apply STAN for, yes? So we said that we've gone through the checklist at the beginning. We said it's appropriate to use STAN on baby. So it's a 36-week or more, membrane is already ruptured, she's at a stable state, and there's no contraindications. I've gone through my initial physiology assessment, and I've seen that it's not a chronic hypoxia, not a chorioamnitis, not a acute hypoxia thing, okay? And I need to now start thinking about where I am to start STAN. Can I start STAN on this baby? Can you see where I'm pointing? Can you see my mouse?
No.
So can I, no, you can't see my mouse, or no, I can't start it on this baby?
I can
No,
see
you
your
can't
mouse.
start STAN.
You can't start STAN.
I can't start STAN. So I can't start STAN if I think that this baby is already along the hypoxia pathway. So I need to start STAN on this baby. That is the only baby that I can start STAN on. Baby that has no hypoxia whatsoever, is not showing any chorioamnitis, or a baby that is facing some hypoxic stresses, but is still stable. That's the baby I can start STAN on, yeah? A baby that's already starting to become hypoxic, I can't set a baseline on it anymore. Remember, I am setting the baseline to my baby. So I need this baby to start from normal. So if you start off with, you've gone through the checklist, okay? Is the baby's baseline within the normal limits? Okay, is the baby spending enough time at the baseline? Is the variability normal? If yes, then I can start STAN. If no, then I can't. Every time we're going in to check, we need to make sure that these things still stand. So the baby is still spending enough time at the baseline. Yeah, there is still normal variability. This baby's not gone completely flat. Remember, there is no test that is 100%. So you are the monitor at the end of the day. It's not the machine. You're using the monitor to help you. Okay. So has the baby starting showing signs of hypoxia? Is the baby progressing along the hypoxia pathway? One of the things that has made our experience here at Kingston helpful with STAN is that we are putting STAN on, hoping that it does not alarm, rather than waiting for it to alarm and then start catching up. So even if I can see, so if baby's spending more time at the baseline, less time at the baseline, if baby is well and STAN has not alarmed, if I reduce the symptom now, then I will make sure that baby never reaches the point that STAN is alarming. If I can see that this baby is well and it's not showing any brain decompensation, I can make sure that this baby remains well throughout the labor. It gives me the chance to actually act and behave and respond to baby way before the emergency is actually happening. If I actually reach the point that STAN is alarming, I need to go back and look at initially the trace. Where amongst the classification am I? Is STAN alarming while I'm here? While is STAN alarming while it's actually, there's nothing do we need to be worried about? Remember, this and this, I'm not using STAN at all. So basically, it's just leaving you in between those two categories. If STAN is alarming, is there a hypoxia that is actually happening? So I need to be worried, or is there no hypoxia happening? In which case, I'm just going to ignore the alarms because this was baby just breaking down a few glycogen molecules, which babies are allowed to do. Okay. If it is because of hypoxia, then I need to make sure that this baby is fine, that make this baby get happier. So I will need to improve baby's situation as soon as I can. So if she's contracting too frequently, I'm going to space the contractions out. If the baby has started showing signs that it's redistributing, I'm going to try and reverse that. I can reduce the contractions or potentially give her a tocolytic to make things better. Okay. If the baby is reaching the point that, okay, we are decompensating and brain ischemia, then I definitely need to deliver the baby. Does that make sense?
Yeah.
Are we all following that through so far?
Yeah, sounds good.
Okay. Any questions? So Natasha's saying that there's a question on the hourly assessment whether the variability is abnormal. So remember that the baby, this stand monitoring is looking for hypoxia. Okay. It's not infallible, as I said. So if the baby is suddenly showing signs that it's not responding anymore, which can potentially happen with a baby that started off normal but has a reduced reserve. So baby
No,
has
I think the decision tree is perfect. I just think that you're asking if it's abnormal. So if you say yes, that is the red line, isn't it?
oh, sorry, that's the other way around. So is it normal? It should be, is it normal?
So either you
Yeah.
change is the variability normal? No, or you change it to is the variability abnormal, and then the red line becomes a yes.
Yeah. Yes. Yeah, I think it's that the wording is wrong. Okay. Okay. Thanks for pointing that out.
I do my best.
Okay. So quick question. The question is about contact. How long or how many checks do we need for Stan to be doing for us to be reassured by the baby's status?
Do you need 4 crosses and 10? No, 4 crosses and a something. I can't remember.
So ignore the rules. Let's make this up as we go. You now have something that checks baby's ECG to make sure that it is fine. How frequently do you need to make a check to make sure that this baby is not harmed?
Frequently.
Good answer.
Surely you want it like every minute or something.
So if you can check it every minute, that's amazing. If you can check it 3-4 times a minute, which is what the machine is supposed to be doing, that is perfect. But we don't live in a perfect world, do we? There are many, many situations where we're not necessarily in a perfect world. Ideally, I need to have a check every minute. Okay, so I need to have a cross within every minute. That's the ideal situation. Or in many books, the minimum situation. Okay, if you are having gaps in between your checks that are lasting more than 4 minutes at a time, theoretically, you can start developing hypoxic changes, especially biphasic changes, when you're not paying enough attention. Okay. However, if I can be reassured by baby's assessment, because if the baby's CTG is completely normal, even if Stan was never on, I can start it now. Even if Stan alarms, I'm going to ignore it. So who cares? Does that make sense? So if I have a normal CTG, I really don't care about how frequently the crosses are. However, this tells me that if the CTG is getting worse, I won't be able to figure out the changes because I don't have good contact. Does that make sense?
Yeah.
So if I have a hypoxic CTG where I'm pushing things towards the limit, if I'm not getting a check every minute, I might not have enough checks to tell me when the baby is becoming unwell. Remember, the machine is checking for 2 things, the ratio and the shape. The shape, it can figure out whenever it does the check. The ratio, it's not just looking for a single time when the ratio is bigger. It needs to make sure that this ratio is persistently bigger for a time to start giving you an alarm. It's trying to avoid the fact that when baby has a normal glycogenolysis, then the ratio is going to change. Does that make sense?
Yes.
Yeah.
So if you have a loss of contact for more than 4 minutes, the reality is you might have missed an episode of increase. That's where the 4 minutes thing comes. If you've had a break of more than 10 minutes, you might have had a 10-minute or a baseline change that was missed. That's where the 4 and 10 minutes comes. You basically need to make sure that the baby has enough contact to give you the signals. But if you have loss of contact that has lasted for 10 minutes or 20 minutes or 30 minutes, if the CTG has remained the same as in normal, within those 30 minutes, you can restart scan again. It's not a problem. Because you would have been ignoring it if there was alarms anyway. It's only when there is problems with contact that you need to be more vigilant in getting the contact. You can't rely on the reassurance of scan if it doesn't have contact. Does that make sense?
Yeah.
And now you can put set the limit in whatever you want or prefer to put it. Be it 1 minute, be it 4 minutes, be it 10 minutes, whatever. It's what you feel clinically you need. What most people agree upon is you need 1 cross per minute. So basically 10 minutes, 10 crosses.
Okay.
Do we have any questions?